Good morning, everybody. I know everybody's very excited about this. You're here at 7 a.m. because I know you want to learn about endocrine emergencies, which, kind of like I alluded to yesterday, we pretty much went into emergency medicine to avoid this sort of stuff. But unfortunately, we need to know it for the board exam. And the good news about this is that some of this are things that we already know, things that we deal with all the time, like hyperkalemia, hyponatremia. So some of those electrolyte things are also thrown into this lecture. It's not all about the glands, okay? We'll keep it moving pretty quickly, definitely board focused, and I'll try to give you the points that I think are most likely to show up on the exam. So let's start with hypoglycemia, since it's the beginning of the day here. Remember that glucose is the sole energy source of the brain. It's the only thing that can use. Remember that your symptoms of hypoglycemia depend both on how low the blood sugar is as well as how quickly it drops. You know already that hypoglycemia can mimic all sorts of things. Can mimic psychosis, TIAs, strokes, things like that. And remember that insulin obviously brings your blood sugar down, but your counter-regulatory hormones, glucagon and epinephrine, work to bring your blood glucose up. Remember that the way glucagon and epinephrine work is that they cause release of glycogen stores from the liver. So the first exam question that we could get from this is, what sort of patient would not respond well to glucagon? That is, who would it not work very well in? It's going to be somebody who does not have very good glycogen stores. So maybe, chronic alcoholic, cirrhotic, neonate, something like that, who doesn't have great glycogen stores, may not respond as well to glucagon. Again, symptoms of hypoglycemia, you know about this. You get your sweating, tremor, anxiety. You can have seizures, things like that. Remember that these sympathomimetic symptoms can be masked by beta blockers. And of course, your neurologic symptoms are all of this: altered mental status, seizures, things like that. Of course, we know to check a blood sugar in anybody who's altered. It's one of the first things we got to do. What causes hypoglycemia? Lots of different things can do it. Of course, you could have an insulinoma. It is a tumor producing insulin. Lots of meds that people take can do it, drugs and alcohol. You could have a tumor outside of the pancreas, again, causing this as well. Liver disease because of depleted glycogen stores and inability to do a lot of gluconeogenesis. Deficiency of those counter-regulatory hormones. You've used up all your epinephrine, for example, because you've got sepsis or you're critically ill and stressed, those sort of things. There's this thing called dumping syndrome, which is a little bit unusual. We don't think about this a lot. If you think about it, normally you're not going to get hypoglycemic after a meal, right? I mean, you just ate. But what happens in dumping syndrome is that food moves through the GI tract too quickly. It goes from the stomach into the duodenum too quickly. It kind of gets dumped in there, causes some stretch, and the pancreas basically ends up overshooting and secreting too much insulin. So this is somebody who actually gets hypoglycemic soon after having a meal, rather than not having eaten. There's some artifactual things that will make your blood sugar look low in the lab, but they're not real. It's not real hypoglycemia. One is if you leave your blood sitting around for too long, the white cells will start to have some glycolysis and eat up your sugar, so don't let it sit around too long. Similarly, if you have leukemia or polycythemia, you just got lots of cells there, also eating up your sugar. Okay, how do you tell whether somebody has an insulinoma, somebody's been having like recurrent hypoglycemia? How do you tell whether it's an insulinoma or the person has Munchausen's and they're just taking some insulin off the shelf and injecting themselves? So what's the test that we look at to distinguish between those two? It's the C-peptide. And if you remember, this is the way it works. When insulin is made in the body, it's made as a pro-hormone, a big pro-peptide. And that pro-peptide is cleaved into insulin and the C-peptide. When you get insulin out of the bottle, there's no C-peptide in that bottle. So if it's an insulinoma, you should be having these elevated C-peptide levels, but if it's somebody with Munchausen who's just shooting themselves up, they should not be elevated. All right? So that's how you distinguish insulinoma versus somebody just giving themselves too much insulin. Treating hypoglycemia, we do all the time. I kind of remember the rule of 50. You can give either an AMPA D50. In kids, you can give D25, 2 cc's per kilo, so 2 times 25 is 50. In neonates, you can give D10, 5 cc's per kilo, so 10 times 5 is 50. Kind of remember it that way. So D50 in adults, D25 in kids, D10 in little neonates. Glucagon, of course, we use all the time for patients who we don't have IV access on, but remember, those patients who will not respond to it quite as well. If somebody has recurrent hypoglycemia, we put them on, drips, right? D10 drips, things like that. If the hypoglycemia we think is from adrenal insufficiency, well, then we need to also treat that. We need to give them some hydrocortisone as well. Now, one other special thing you need to remember is octreotide. Octreotide is an antidote for sulfonylurea overdoses. So if you remember, the sulfonylureas, all the ones that end in "ide," glyburide, all these sorts of things, the way they work in these non-insulin diabetics is they take their glyburide and it stimulates the pancreas to secrete a little bit of insulin. So it secretes a little bit of insulin, and that's why it works. Octreotide does the exact opposite. It actually blocks insulin release from the pancreas. So in that respect, it would be a perfect antidote for sulfonylureas. And of course, that's when you would use it. The sulfonylurea overdose, where they're getting severe and refractory hypoglycemia, that's when you would use octreotide. So those are your mainstays of hypoglycemia treatment. Okay, the next topic here that has to do with sugars comes from one of those LLSA articles that was talking about all the different oral agents that you can use for diabetes. And there's all sorts of different classes, and it was one of these really long, I thought pretty technical and very difficult to read articles, at least for me. Hard to kind of put it all together. So what I tried to do is take it and put it into just 2 slides for what I thought were the biggest concepts and most testable points, okay? There's obviously lots more detail on that article that we're not going to go into. But I think this is the stuff that's fair game for the board exam. The first thing to realize is that when you're treating diabetes with these oral agents, there's 2 main classes, if you think about it that way. The first class are hypoglycemics, that is, things that literally drop your blood sugar. The second class are anti-hyperglycemics. They really work by keeping your blood sugar from just going up in the first place. Does that make sense? So you have your hypoglycemics and your anti-hyperglycemics. So first, let's talk about the hypoglycemics, the ones that actually drop your blood sugar. The sulfonylureas would be the classic, and that's the biggest category here that we already talked about a little bit. Chlorpropamide, tolbutamide, glyburide, all these ones that end in "ide" are the sulfonylureas. They stimulate the pancreas to release a bunch of insulin. In overdose, they cause profound hypoglycemia. They all have very long half-lives, so they stick around for a long time. And that's why when people overdose on these and they're hypoglycemic, they're getting admitted to the hospital because you know it's going to be there for a long time. The only other trivia fact that I want you to know about these sulfonylurea agents is that chlorpropamide can cause SIADH. We'll talk about that more later, but just a little trivia fact because it could show up in one of the answer choices for a question. So those are the sulfonylurea agents. And of course, in overdose, they cause bad hypoglycemia. The other one that's in this hypoglycemic class is Prandin. What is it, repaglinide or apaglinide? You don't have to know the mechanism, just know the same thing, that it's one of these hypoglycemics. So in overdose, it's going to cause hypoglycemia. Okay? So if you overdose on any of the things on this slide, you're going to get hypoglycemic. Now, the anti-hyperglycemics, the reason we care about that difference is that if you overdose on this, you're probably not going to get hypoglycemic. And that's important both for your clinical practice as well as for the board exam. So, of course, the one that we see all the time is metformin. Metformin, again, overdose on metformin, they're probably not going to get hypoglycemic. And the other trivia fact to know about metformin is that it can cause a lactic acidosis. It can be very severe, especially in patients who have renal insufficiency. So you need to know that association. So that's metformin. There are these alpha-glucosidase inhibitors. Basically, these are sugar blockers. Think about it this way. They work down in the intestine, and they inhibit the intestinal hydrolysis of these polysaccharides so that it can't be absorbed. So it's blocking these sugars from being absorbed. That's why it's an anti-hyperglycemic agent. Again, in overdose, it's probably not going to cause your blood sugar to drop. The other trivia fact is that because this blocks sugars, if you're hypoglycemic for some other reason, if you give oral sucrose, you won't be able to absorb it. Okay? And the last class of these anti-hyperglycemics are the thiazolidinediones. These are the ones you know like Avandia and Actos, these types of medicines. And again, limited overdose experience, probably not going to cause hypoglycemia, certainly not as much as the other ones might. We know that these can all worsen heart failure, so I think you should know that trivia fact. And then there are some other side effects. I think probably the one that's worth definitely knowing is that Avandia now has a black box warning for acute MI. So that's the other thing that I'd probably write down if you're going to remember any other factoid. Okay, so you got your hypoglycemics, which an overdose will make your blood sugar drop, the anti-hyperglycemics, which will not. So some pearls for hypoglycemia. We already mentioned this. Always admit your sulfonylurea overdoses. Most get symptomatic early, but it can be delayed. Octreotide is an antidote for that. We talked about this a little bit in the neurology section. Give thiamine with your glucose if somebody's hypoglycemic, but they're also malnourished. So if they're really malnourished, but they're hypoglycemic, yes, go ahead, fix their hypoglycemia, but while they're down in the ED, give them some thiamine as well so that they don't end up with Wernicke's encephalopathy. And we also mentioned that glucagon may not be effective in patients with poor glycogen stores. Okay, so that's hypoglycemia. Let's move on to DKA, which again, we treat all the time in the ED, so that's good. Pathophys is pretty easy. You don't have insulin, your blood sugar goes up. Your blood sugar goes up, you're going to get an osmotic diuresis. You're going to get dehydrated, you're going to lose fluid, you're going to lose electrolytes. The other thing that happens is your blood sugar goes up, but it can't get into the tissues. So because of that, you break down the fat into fatty acids. That's why you end up with the ketoacidosis. And then, of course, that bad ketoacidosis is what causes the Kussmaul respirations that you oftentimes see in these patients who are trying to compensate by doing some deep breathing. So that's the pathophys. Precipitants of DKA, the truth is, for all of these endocrine emergencies, just about any acute stressor can precipitate these things. So you don't usually have to memorize a big list. What I like to do is for DKA, I at least start looking for some of the I's as a first place to start. So infection, infarction, like myocardial infarction, infraction or lack of insulin, basically. They haven't taken their insulin. And IUP, intrauterine pregnancy. So pregnancy. But anything here, any of these things on this list, and any acute stressor can really cause it. But those are some places to start looking. What about fluids and bicarb? So obviously these patients are dry, they need initial fluid resuscitation, you're going to replace their electrolytes, and you're going to put them on an insulin drip. Remember, you want to look at their potassium before you start that insulin drip, because if their K's real low and you put them on insulin, remember, once you put them on insulin, you're going to drive their K down. So if their K's real low and you already start driving it down without repleting it, you could precipitate a cardiac arrest by making them really hypokalemic. So you just need to know what their potassium is. What about bicarb? You know, bicarb has always been one of these controversial things in DKA, and we know that they won't test you on controversial items on the board exam. But there are some facts about bicarb that I think are very testable for the board exam. They won't say, should you have given the bicarb or not? But they will ask you some things about bicarb therapy that you should know. So let's kind of go through these. And actually, before I hit this, let me just tell you a practical thing. Somebody's in DKA, let's just say they got a bicarb of 15. You give them an amp of bicarb. How much is their bicarb going to go up? How much is their CO2 going to go up, do you think? So it's going to go from 15 to what? Like real good? Did you fix it a lot? Maybe 16. Maybe it goes up 1. So the first thing, just from a practical standpoint, is it doesn't give you a huge correction of acidosis when you're given a bicarb. But these are some of the hazards that I think could be very tested. The first is what's called the paradoxical CSF acidosis. What happens here is you're giving somebody bicarb in their bloodstream, but it gets converted to CO2, goes and crosses the blood-brain barrier, and then when it goes up in the brain, it kind of gets trapped again and causes this CSF acidosis. So you're given bicarb, and you're making their blood pH look good, but the pH in the CSF actually starts getting worse, paradoxically starts getting worse. And that's not good. That can give you cerebral edema, that can give you seizures, altered mental status, things like that. So one of the concerns with bicarb is this paradoxical CSF acidosis. Another concern about bicarb is that it shifts your oxygen hemoglobin dissociation curve to the left. If you remember what that means, it means that the hemoglobin becomes stingier and it doesn't want to drop off oxygen at the tissues. Well, if you've got a big old acidosis and you're hypoperfused and dehydrated, you kind of want oxygen at your tissues. So it's going to decrease tissue delivery of oxygen when you give sodium bicarbonate. That's another thing they might ask you about. And of course, bicarbonate is sodium bicarbonate, so you could overload the sodium, and you could drive the potassium too low. We talked about that too. It turns out that bicarb actually is independently associated with cerebral edema in kids who have DKA. So it's actually a buddy of mine who, he and his wife did a beautiful study published in New England Journal. They looked at a bunch of kids in DKA, and they said, which kids go on to develop cerebral edema, and can we predict it? And they used the fancy statistics to figure out what the independent predictors were, and they found 3 things in kids that independently predicted who would go on to develop the cerebral edema. 2 of them were like abnormal lab values. Well, we don't affect that. But only one thing was a therapy, was something that we do, and it was at giving bicarb. So it turns out that giving bicarb was an independent predictor of kids going on to develop cerebral edema. So it's a reason to, avoid bicarb, in general, but certainly in kids, I'd avoid giving bicarb and DKA. And I think those things are the testable facts. Okay, what about sodium and phosphate and DKA? Well, there's this thing called pseudo-hyponatremia. It actually is a real hyponatremia, even though it's called pseudo. But usually when you're hyponatremic, it's because you've lost a bunch of sodium particles. Here, it's actually more of a dilutional hyponatremia. Your blood sugar's up, your blood sugar's real high, so you start to pull in fluid from the tissue into the bloodstream, and it dilutes out your serum sodium. Okay, it is a real hyponatremia, but it's a dilutional type. And there's a formula that tells you how, depending on how high your glucose is, how low is your sodium going to become. And this is the rule. For every 100 that your blood sugar goes up over 100, your serum sodium drops by 1.6, okay? So to give you an example, if you have a serum glucose of 600, that means you're 500 above 100. 5 times 1.6 is 8. So instead of your serum sodium being 140, it should be 132. So what I mean is if you get somebody's chemistries and it says glucose 600, sodium 132, that makes perfect sense. That low sodium is from that high glucose, okay? And here's a reason that might be important. Let's say you get somebody's chemistries and it says glucose 600, sodium 140. It would be real easy to blow by that and say, oh, sodium's normal, right? But it's actually not normal. They're really dehydrated. That 140 is really, when you correct for the sugar, is like 148. So they're very, very dehydrated, and that's why you need to know about that. Okay. Sugar goes up, sodium's going to go down. You lose phosphate, okay? Basically, because of the diuresis, you lose magnesium, you lose potassium, you lose phosphate, you're peeing out all this stuff. Hypophosphatemia, what do you need to know about it basically for this? You need phosphate to make ATP. ATP is energy, so if you don't have energy, you get weak, and you can get respiratory depression. Those are the main things that can happen with hypophos. Okay, what about potassium? We know this is important in DKA. If you measured somebody's total body potassium in DKA, it's going to be down. They've been peeing it out. Their total body potassium is going to be low. But the serum potassium could be high, low, or normal, depending on their renal function, depending on their acid-base status, things like that. So we don't know initially what their potassium is going to be. Remember that everything we do when we start to treat DKA is going to send their potassium down. You give them insulin, drops their potassium. You correct their acidosis, drops their potassium. So wherever we started, we're expecting it to go down. So what that means is if their initial potassium is already really low, then you want to start fixing it with, pretty aggressively before you give your insulin. If the initial serum potassium is in the normal range, or pretty normal, well, you can start giving them their insulin and everything, but you need to give them a little bit of potassium because you know it's going to drop. If their initial potassium is high, well, you go ahead and give them their insulin, of course, but you want to hold your potassium until it comes down into the normal range, and you know that they're making urine. You know that they got functional kidneys that are going to pee it out, okay? So just remember that you got to replete the potassium. Okay, so complications of DKA treatment, just to kind of review. One, hypoglycemia, because we stick them all on insulin drips, right? And that's why we start them on some sugar as well. Hypokalemia, because we're driving their potassium down. Bicarb therapy, if you gave it, could cause that CSF acidosis and other things we talked about. And the cerebral edema, nobody knows the exact etiologies of this, but we do know that in kids, bicarb is an independent predictor of who gets it. So that's DKA. What about AKA, alcoholic ketoacidosis? What's the story for this? Okay, you're at a board review course in Vegas, of all places, right? You are in lectures all day long. You say, I'm out. I can't deal with this anymore. So you go to one of the many fine establishments here to start drinking, and you do binge drinking, and you're drinking, and you're drinking, and you're drinking. And of course, if you're drinking, you really don't need a lot of food, right? I mean, you got alcohol. So you're not eating a lot. You're just going for the alcohol sort of thing. Okay, you do your binge drinking, you stop drinking, and after that you start to feel bad. Now we know that you're going to feel bad, right? But now you're feeling really bad. It's 48 hours later, and you're feeling horrible. You're getting belly pain, you got nausea, you got vomiting. You're like, whoa, this is more than just your usual hangover. This is bad. So what's going on here is you have alcoholic ketoacidosis. You're drinking all this alcohol. The alcohol inhibits gluconeogenesis, okay? So you're kind of getting a relatively hypoglycemic. You also haven't been eating a lot of food. And you're also starting to develop a ketoacidosis. So it's a ketoacidosis, and with kind of like you could have some mild hypoglycemia as well. But belly pain, nausea, and vomiting. Now, this person comes into your ED. What should their alcohol level be? Should it be high? No, it should be low or negative, right? This is when somebody has stopped drinking. So alcohol level in AKA is either low or negative. This is when they've stopped drinking. It's more like alcohol withdrawal in that respect. What about ketones? Well, I told you it's a ketoacidosis, so if you measured somebody's blood ketones, they should be positive. But remember, there's this weird thing about the urine ketones that we learned. Remember that in the urine dipstick only picks up acetoacetate and not beta-hydroxybutyrate. And it turns out in alcoholic ketoacidosis, the vast majority of the ketones are beta-hydroxybutyrate, not acetoacetate. So because of that, even though it's a ketoacidosis, don't be fooled on this exam. When you do a urine dipstick, it could be either negative or just kind of like weakly positive. You're like, oh, that's not really impressive. And the way I kind of remember it is I just think, you know, when they invented the urine dipstick, they got to A and they never got to B. So it picks up the acetoacetate, but it doesn't pick up the beta-hydroxybutyrate, all right? So that's the way you remember that one. So how do we treat this? You know, person came in, they binge drinking, now they're belly pain, nausea, vomiting in the ED. You're like, oh, I kind of know how to do that. I give them some Zofran, I give them some fluids, right? That's all fine. But the thing that's different about this is you don't just give them normal saline, you need to give them D5 normal saline. So they need that substrate as well to start to reverse the ketoacidosis. So that's the special thing and the very testable thing for these patients. So that's AKA. All right. What about this one? Love this name. Hyperosmolar, hyperglycemic, non-ketotic state. And it is just kind of what it says. Your osmoles are high, you got a really high sugar, but you don't have ketones. This is really good for the exam because, you know, there's DKA where your blood sugar goes up. There's this where your blood sugar goes up. But they're different disorders, and there's lots of this kind of like compare and contrast sort of thing here. So that makes for a good exam question. So let's just kind of look at this side of the slide here that talks about the similarity to DKA, but the important distinctions. You could write some good exam questions from that side right there. So let's look at it. So there's no ketoacidosis. It's this non-ketotic state versus DKA is ketoacidosis. So that's an obvious one right there. The glucose is usually really high, like oftentimes over 1,000. This is when they come in 800, 900, 1,200, really, really high glucose. DKA, you know, it's usually under 600. Osms, very, very high. With this, it's usually non-insulin dependent diabetics. In fact, maybe about half of the people who present with this had no history of diabetes, and this is their first presentation of type 2 diabetes. Versus DKA, right, it's our insulin-dependent diabetics, type 1 diabetics here. So that's also a distinction. This has a higher mortality, has more, you know, worse associated symptoms. They tend to be older patients with comorbidities. And so it's a higher mortality than DKA. And the onset of this is also longer than DKA. That is, DKA has a shorter onset. You know, I stopped taking my insulin yesterday, and now I'm not feeling great, or 2 days ago, and now I'm not feeling great. Versus this can develop over days to weeks, all right? So those are the important distinctions. I think you should know that for the exam. Precipitating factors, you don't have to memorize any of that, okay? Any acute stressor can do it. Any acute stressor in the right patient, especially someone elderly, can do it. Comorbidities that some of these patients have. So again, oftentimes it's an older patient with renal disease, cardiovascular disease, that are on medicines like renal medicines and cardiac medicines. You don't have to memorize the whole list. If you just remember that, renal insufficiency, vascular disease, you know, diuretics, cardiac type medications in an elderly patient, those are the types of patients that end up with this disorder. On exam, they're profoundly dehydrated, because remember, their sugar is way, way high. Profoundly dehydrated, they're altered, okay? And those are the main findings. Treatment, basically you need to rehydrate them. You need to give them normal saline. So you need to give them some normal saline. They have very large fluid deficits, but you don't want to fix this too quickly. So again, half the deficit over the first 12 hours, and the rest over the next 24 hours. If you fix it too quickly, you can end up with cerebral edema, so let's not do that, okay? And a general concept for most of these things is that they didn't get there in an hour. You don't need to fix them in an hour. All right, let's move to some good hormones now. Let's talk about our friend the thyroid. Quick review of how things work with the thyroid. Okay. You got your hypothalamus, which sends out thyroid-releasing hormone to the anterior pituitary. The anterior pituitary makes TSH, thyroid-stimulating hormone, which does just what it says. It goes to your thyroid, and it says, hey, thyroid, make some thyroid hormone. The thyroid makes T3 and T4. Remember, T4 peripherally gets deiodinated and converted into T3. And remember that T3 is the one that's, much more powerfully active than the T4 is. Okay, so that's the way things normally work. And as you know, thyroid hormone kind of revs up your metabolism, gets everything going. A concept to remember about the thyroid: when there's a problem with the thyroid, it usually is the thyroid itself. It's usually not the hypothalamic pituitary axis. It's usually a primary problem with the thyroid itself. So when we talk about hyperthyroidism, the most common cause is the thyroid itself with Graves' disease. It's an autoimmune disorder where the antibodies look like TSH. So it starts stimulating the thyroid, and the thyroid itself starts kicking out lots of thyroid hormone. So that's the most common thing, would be Graves' disease. But other things in the thyroid itself can cause it as well. Toxic adenomas, multinodular goiters, thyroiditis, where it becomes inflamed and starts leaking out this thyroid hormone, okay? So it's most likely the thyroid itself. But you can have things in the pituitary as well, like a pituitary adenoma, that can do it. But usually it's the thyroid itself. Signs and symptoms of hyperthyroidism. Remember, everything's all revved up and active. So you get nervous, you get tremor, which you can sometimes just see like in the eyelids. You don't tolerate heat real well because you're already generating lots of heat. You can have weight loss, tachycardia. You're probably going to have tachycardia. A hyperdefecation. It's not really diarrhea. It's just like everything's moving through you real fast. You can have if you're lucky, you got a big old goiter with a bruit over it. That's always a good hint. And then remember, only in Graves' disease, not in the other types of hyperthyroidism, but in Graves' disease, you can get this exophthalmos that you see there, and you can get the lid lag. If you remember what lid lag is, you have a patient, they're looking straight ahead, and you say, look down at your shoes, and they look down. When you look down, normally your eyeballs move down, and your lids move down exactly with your eyeballs. So you never see, for example, the sclera on the top of the eyes. With lid lag, eyeballs move down, but the lid lags. It doesn't move down as quickly, and you actually may see that sclera up at the top of the eyes. Those are the things that are seen in Graves' disease. Another thing you can see just in Graves' disease for hyperthyroidism is this pretibial myxedema. And you can see what it looks like there. There's kind of like yellow, waxy nodules there underneath the skin as part of the skin and the dermis. Okay, it's accumulation of these mucopolysaccharides. Again, that's in Graves'. Okay, risk factors. The thing I would just remember is that women, if there's a thyroid problem, it's more likely in women, whether it's high, low, whatever. Women have the thyroid problem more than men. Labs. So there's some good test questions you could get out of this. So first of all, because it's the thyroid itself, the vast majority of the time, you would expect your thyroid hormones to be high, right? The thyroid is making all the stuff, so your T4, T3 are going to be high. And because of negative feedback, that means your TSH is going to be low. So low TSH, high T4 and T3. Treating mild hyperthyroidism, pretty simple. You just give them a little beta blockers. They might get some PTU. We'll talk about that more. They may get iodine or surgery, but that can be basically outpatient stuff for mild thyrotoxicosis. Thyroid storm, on the other hand, this is now the life-threatening severe spectrum of hyperthyroidism. This is life-threatening. This is when patients are coming into the hospital, okay? Again, you do not have to memorize a whole list of things that precipitate this. The only thing I would circle to remember is administration of IV contrast. So somebody who's got some hyperthyroidism, they get their IV contrast for their CT or their whatever it is, that could be a precipitant that puts them into thyroid storm. So just kind of remember that one. But any acute stressor can do it. The hallmark of thyroid storm, when you know it's thyroid storm, is CNS dysfunction. They're altered. Now things are starting to go really bad. Altered mental status, they tend to get an elevated temperature, very tachycardic, even out of proportion to their fever. There's no lab test that tells you, oh, you're now in storm versus just thyrotoxicosis. It's the clinical appearance. It's the way they're looking. It's this altered mental status, elevated temperature, those sorts of things. That's storm. Okay, let's talk about the lab tests again with a little more detail now. So again, remember, because it's the thyroid itself, T4 and T3 are usually going to be elevated. TSH is going to be low. But what about these kind of other things? I call them these like other tests. Remember that in thyroid storm and in hyperthyroidism, all these other things go up for the most part. So your sugar goes up, your calcium goes up because of some bone turnover, your LFTs go up, but your cholesterol goes down. It's the one thing that's different is the lipids. The cholesterol goes down. And the way I remember this is I just picture somebody with hyperthyroidism and thyroid storm, and they're so active and they're so up and they're so active that everything went up, but they dropped their cholesterol because they were so active, all right? I do not think that's the actual pathophysiology, by the way, okay? But it'll help you remember it for the exam. So that's the one, and that's a really good testable multiple choice question. How do we treat thyroid storm? Somebody comes in, they're altered, tachycardic, what are we going to do? Well, the first thing we do is just our general supportive care, right? Get a line in them, give them some fluids, kind of work on their electrolytes. Give them a dose of steroids. You give them a dose of corticosteroids like hydrocortisone. And the reason that is that they could have a relative adrenal insufficiency. That is, their adrenals are working fine, but their system is so revved up, their adrenals need to work overtime. So you give them a little extra help. So thyroid storm, you give them a little dose of hydrocortisone. Now, we want to start treating this thing. So first thing we want to do is block all these peripheral effects of the thyroid hormone. So for that, you use beta blockers, and you use propranolol. You just basically titrate it up to start getting their symptoms under control and get their heart rate under control. Why propranolol versus other beta blockers? What extra bonus do you get by using propranolol? It helps block the peripheral conversion of T4 to T3. Okay, so it's just like an extra bonus you're getting. You're going to use a beta blocker. Why not use one that also can help decrease peripheral conversion of T4 to T3? So you give your propranolol, get their heart rate under control. You're like, okay, that's doing better. Now we want them to stop making more of this thyroid hormone. So for that, we use PTU. That's the propylthiouracil. It blocks the enzyme, so you stop making all that thyroid hormone. Okay, so that's good. So you got their heart rate under control. You gave them some PTU so they stop making the thyroid hormone. Now you want to block the release of the hormone that's already been made. So some of it's already there. We want to block the release of that. So for that, you use iodine, okay? And there's different ways you can do it. There's that saturated solution of potassium iodine or orographin, like an oral contrast with iodine, that sort of thing. But basically no iodine. That's what you need to know. But there's one important point. You need to wait at least an hour after the PTU before you give the iodine. And the reason that is you need to shut down the machinery before you give the iodine. Because otherwise, if you just give the iodine, it gets sucked up and they actually make more thyroid hormone. So get their heart rate, give them the steroids, get their line, give them some fluids and steroids, get their heart rate under control with some beta blocker, give them some PTU to shut down the machinery, wait at least an hour, and then give them some iodine to block the release of the hormone that's already there. And then, of course, the final step is figure out what the underlying problem was to begin with, their pneumonia, their whatever it was, their acute precipitant, and treat that. So that's thyroid storm. The last thing I want to tell you about hyperthyroidism is there's this special kind of form of it that can present in the elderly patients that's called apathetic thyrotoxicosis, and it's a good name for it because it is thyrotoxicosis. They're hyperthyroid, but they kind of look apathetic. They don't look like your typical revved up hyperthyroid person. They have, lethargy, slowed mentation, kind of an apathetic faces, droopy eyelids. So they're looking kind of like, down and droopy, not all revved up. However, they have tachycardia, they can have atrial fibrillation, they can have congestive heart failure. So it is true hyperthyroidism going on. They just look differently. Like many things, the elderly can present differently. Okay, so that was high thyroid. Let's talk about hypothyroidism now. Again, it's the thyroid, it's usually the thyroid itself that's the problem. And so probably one of the common things would be somebody who had treatment for Graves' disease. So, they had some surgery or they had some radioablation or they had something to mess up their thyroid itself. Iodine deficiency, autoimmune, again, destroying the thyroid itself. Lithium can cause it, amiodarone can cause it, and then of course, less commonly, it's pituitary or hypothalamic causes. But that happens, it's less common than the thyroid itself. Signs and symptoms of low thyroid, remember everything's kind of slow and sluggish now. So they're weak, they're lethargic, they don't tolerate the cold because they're not making much heat on their own to begin with. They can gain weight, they're constipated, thick skin. They can have generalized non-pitting edema, this mixed edema. Oh, and by the way, there's the picture. I mean, you see the difference between the guy, right? Here he is, really hypothyroid. Hey, you treat him up a little bit, looks back to normal there. Other things that you can see with hypothyroidism, you can see hair loss, especially the lateral third of the eyebrows. That's a great place to look for hypothyroidism, lateral third of the eyebrows. Their mentation can be slowed, they're altered, they can go all the way into a coma. Cardiac things, of course, bradycardia. I mean, if you're not bradycardic, you're probably not hypothyroid, right? They pretty much go together. But you can also develop heart failure, pericardial effusions, low voltage on your EKG because of that, those sort of things. Okay, labs for hypothyroidism. Again, it's the thyroid itself, so the T4 and T3 should be low, and the TSH should be high, again, in the vast majority of cases. What about these other things? There are all these different hypos that can occur. So you can get a low sodium. You can get a low blood count, anemia. If you're in mixed edema coma, you can get low PO2. You can get a low temperature. So all these things go low except the lipids, which go up, okay, just like the opposite before. So on this one, they're so slow and sluggish and everything's going down, but they're so slow and sluggish that they get high cholesterol, all right, if you just remember it that way. Mixed edema coma, kind of like thyroid storm. This is the life-threatening end of hypothyroidism. Again, more common in women, again, elderly women especially. Stressors, again, you don't have to remember all these things. Basically, any acute thing can stress it. Obviously, if you're not taking your thyroid hormone replacement, that could cause it. The one other thing I would just circle here is cold exposure. So for some reason, you know, they're not real cold, generating a lot of heat to begin with. They get out in the winter, they get out in the cold. It's one of the things that can precipitate it. So that's probably when you're going to see this, is during winter. You're going to have an elderly woman come in comatose. This is what you need to be thinking about. One other thing to remember here, some signs for hypothyroidism. They get these hung-up reflexes. These hung-up reflexes. What this is a delayed relaxation phase. So just to give you an example, if I were doing a biceps reflex, a normal biceps reflex, right? Like that, that's normal. Up, down, up, down. Hung-up reflex, like that. Up, delayed relaxation phase, okay? So they get those as well. And of course, they can get hypothermic and edema, we already talked about. So how do you treat mixed edema coma, this really severe hypothyroidism? Again, supportive care. You give them some fluids, some warm fluids. You do some rewarming, those sorts of things. Get rid of the pneumonia or whatever the underlying cause is. But basically, they need thyroid hormone. And the thing to remember is that you give them intravenous T4, not T3. The T3 is just too powerful and too active and can give you cardiac dysrhythmias. All right? We don't want VTAC, not good. So you give them intravenous T4 is what the answer is. And they also get a dose of corticosteroids, okay? And the reason we give it to people in mixed edema coma is, look, what if I'm wrong? What if it's not the thyroid itself? What if they're actually hypopit? What if they actually have hypopituitarism and they also have adrenal insufficiency? So we also give them corticosteroids just in case. So whether it's thyroid storm at one end or whether it's mixed edema coma at the other end, they both get a hit of hydrocortisone. That makes it really easy to remember. Okay, so that's the thyroid. Let's move on to the adrenal. Speaking of hydrocortisone. All right, our friend the adrenal, remember these two little glands, they sit there on top of the kidneys. The cortex makes your cortisol, your aldosterone, basically your glucocorticoids, your mineralocorticoids. The medulla is what makes your epi, norepi, those sorts of things, okay? And adrenal insufficiency is basically when you're lacking the activity of this, mineralocorticoids, glucocorticoids, or both. Now, unlike the thyroid, where the thyroid, it's usually the thyroid itself, the adrenal, it's usually actually the hypothalamic pituitary axis. It's usually not primary adrenal insufficiency. It's usually not the adrenal itself. So primary adrenal failure, that is, the adrenal itself is messed up, is a less likely cause. What's the most likely cause? I mean, why do people get adrenal insufficiency most likely from what? Steroid withdrawal. The person was chronically on steroids. Their adrenals atrophied because they were chronically on steroids, so they don't want to make a lot of cortisol anymore. They abruptly stop taking their steroids, and they get adrenal insufficiency. So usually it's the hypothalamic pituitary axis, not primary adrenal insufficiency. But let's talk about the rare one first. So primary adrenal insufficiency. What causes the adrenals themselves to kind of shut down or not do real well? Well, one of the most common ones is Addison's disease, which is basically an autoimmune destruction of the adrenal gland, which, of course, as you can see from the fine picture here, JFK had, okay? So you could have autoimmune destruction. You could have an infiltrative disease, sarcoid, amyloid, some infections like TB, fungal infections, septicemia can do it. You can have hemorrhage into your adrenal glands, right? So you could have it from trauma. You could have it from over-anticoagulation. You could have it from that Waterhouse-Friderichsen syndrome, remember, with meningococcemia. All those sorts of things can do it. You could have tumors that can infiltrate your adrenals. Drugs, etomidate. We all use etomidate, right? You're going to intubate somebody. If you remember, single dose of etomidate will drop your cortisol level, but probably won't cause any clinically important adrenal insufficiency. But multiple doses of etomidate, or when they used to put people on etomidate drips for sedation, frank adrenal insufficiency. We already talked about meningococcemia. Okay, so how do you tell when the adrenals themselves are messed up? That's when you do that cortisol level and a corticotropin stim test, the cosentropin stim test. So here's the way that works in general. You check someone's baseline cortisol. Okay, you get the number. You give them a little bit of this corticotropin, which is basically ACTH. That's what it is. And remember, ACTH should stimulate the adrenals to make some cortisol. So you give them some of that, and then you measure the levels of cortisol, like at 1 hour and at 6 to 8 hours. And it should be going up, right? If the adrenals are working, it should go up. And there's different cutoffs of absolutes or relative increases, which we don't have to know. Okay, but basically, if it's not going up the way it should, there's something wrong with the adrenals themselves. That's the way that test is. What about this hyperpigmentation thing, right? So if you have primary adrenal insufficiency, that is, your adrenals are messed up because of your, Addison's disease or your sarcoid or amyloid, you can get hyperpigmented. Why does that happen? Who remembers? Okay, I heard some about the ACTH. That's partially right. MSH, I heard some MSH. Yeah, so basically, here's what happens. When your adrenals aren't working, your body wants you to get more cortisol. The way it does that is it secretes a bunch of ACTH, right? But when ACTH is made, it's also made as a big propeptide. And part of that propeptide includes MSH, melanocyte-stimulating hormone. So as you're making this big propeptide and you're making the ACTH to try to get those adrenals going, you're also making melanocyte-stimulating hormone, which is why you get hyperpigmented, okay? So remember, you're only going to get hyperpigmented in the primary adrenal failure. If your adrenal failure because the pituitary, not making ACTH is the problem. So you're not going to make MSH either. So you can't get hyperpigmented, okay? So only get hyperpigmented in primary adrenal insufficiency. All right, and what about the secondary and tertiary? We talked about this as little. So it could be a pituitary problem. You got a tumor in your pituitary, messing things up there and inhibiting your ACTH secretion. It could be the hypothalamus itself because of the steroids and the feedback we talked about as well. Okay, labs. Here's some testable question. The most common lab abnormality in adrenal insufficiency is hyponatremia. Hyponatremia, that's because you lack your aldosterone, so you don't hold on to your sodium. So hyponatremia is the most common. You also might see hyperkalemia because of your lack of aldosterone, okay? And if on the exam you see a chemistries and they see a low sodium and a high potassium, go for adrenal insufficiency. That's probably what they're going for. So low sodium, high potassium, you really got to think about adrenal insufficiency. But reality is most of these patients don't have it, but on the board exam, they might, okay? So low sodium, high potassium. Of course, your glucose can be low because you don't have all those glucocorticoids. And just something to kind of remember, your eosinophils can be high, okay? But remember, low sodium, high potassium. How do patients with adrenal insufficiency present? As you remember, they can present with hypotension and refractory hypotension, but you may not remember that they can present with fever. So not all fever and hypotension is sepsis, okay? It could be adrenal insufficiency as well, which is why when you're resuscitating and it's not getting better and something's going wrong, you really need to think about adrenal insufficiency. Treating it, fluids for their low blood pressure. And again, here we're probably going to use D5 normal saline, not just normal saline, because of the lack of cortisol. Hydrocortisone is the answer. I mean, you have to give the steroids, basically. If you do not give steroids, you could give all the pressors and all the fluids and all the everything you want. They're going to die. Does not matter. You have to replace the steroids. So hydrocortisone is the classic thing that you would use. Turns out, just as kind of a style point, it interferes with that cosentropin stimulation test. So if you really want to be nice to your internist friends, you can use dexamethasone instead. And some people will add to dexamethasone fludrocortisone, which is a mineralocorticoid. But you can use, for the exam, the answer is probably going to be hydrocortisone. And we always give everybody like 100 of hydrocortisone, but you can give them more. If it's not working, give them 200, give them 300. You know, they're not going to develop Cushing syndrome right in front of you, all right? So save their lives. Make them better. So fluids, steroids, pressors. All right, speaking of Cushing's, what is Cushing syndrome? So this is the exact opposite. This is excess cortisol. You got too much cortisol going on. How does it happen? Well, most commonly, you just took steroids for too long. That's easy. Maybe you have an adrenal neoplasm making cortisol. Maybe you have a pituitary adenoma secreting ACTH, making the adrenals make cortisol. Maybe you have a carcinoma of some sort, like a small cell carcinoma, that's also secreting ACTH that makes your adrenals make cortisol, okay? So basically, it's excess cortisol that's causing Cushing syndrome. If you remember what they look like, they're obese, but they have truncal obesity. They're not big all over. It's this kind of central truncal obesity. They can be hypertensive, and they can have, of course, glucose in their urine. But they get these other physical findings, all these funny things, like the moon facies, right? This very round face, looks just very round, moon facies. They get buffalo hump, this kind of, big old deposition of fat or whatever it is back there in the back of the neck there. And they can get these purple stria. They look like stretch marks, except they're all kind of purple stretch marks. So they get all the fun moon face, buffalo hump, purple stria. Congratulations, you now have Cushing syndrome. Oops, sorry about that. So treatment is basically to get rid of the cortisol, get rid of the source. So it's either getting rid of the steroids, tapering them off, or whatever you need to do, fixing the adenoma, those sorts of things. So that's it for those. Now let's talk about SI-ADH. Where does ADH come from in the body? Remember? Ooh. Pituitary, yeah, it comes from the pituitary. The posterior pituitary, right? So this is the one that comes from the posterior pituitary. And I'll be honest, when I was learning this stuff, I had a hard time with this whole SI-ADH versus diabetes insipidus, and what does it do to your sodium and your blah, blah, blah. To me, the easiest way to think about that is to just kind of work through the name. ADH, anti-diuretic hormone. So if you had a diuretic hormone, that would make you pee. If you have anti-diuretic hormone, it makes you anti-pee, right? So you're going to actually hold on to fluids instead. So what this does is it makes you hold on to fluid. And if you think about what that's going to do, is that's going to dilute out your serum sodium and concentrate your urine. So if you just remember that and work through it, you'll get it right. Why do you have ADH in your body? Well, if you're dehydrated, your posterior pituitary says, hey, little anti-diuretic, please, because we need to hold on to some fluid. So that's what it normally does. That's what its purpose is. SI-ADH is the syndrome of inappropriate secretion of ADH. It's basically the posterior pituitary gone wild, unregulated, just secreting a lot of this anti-diuretic hormone. Again, you have too much of an anti-diuretic. It means you're going to hold on to fluid, dilute out your serum sodium, so you're going to have a low sodium and a very concentrated urine. Now, that's not what we normally see, right? If you just think about this. If you see somebody with a low sodium normally in the emergency department, what's their urine look like? Is it all concentrated? No, it's the opposite. Their sodium's low, so your body's like trying to dump the water, okay? So they get dilute. But this is where things have gone awry. So they get a low sodium because they've held on to the water, all right? That's what SI-ADH is. So you see somebody with a low sodium but a really dilute urine, and you say, I think that's SI-ADH. Now you got to figure out what caused it. There's 3 places to look: the brain, the lungs, and the medication list. And so the answer is probably going to be on one of those 3 somewhere. So pretty much anything in the brain can do it: tumor, stroke, infection. Things in the lung can do it, infection, TB, fungal, PEs, whatever. And then there's a ton of medicines that can do it. There's no way anybody can remember all of them, okay? But there's lots of them that can do it. But don't forget our friend, chlorpropamide. Remember that one. That was that sulfonylurea agent that also causes SI-ADH. It's just a really good testable trivia point to know. So that's SI-ADH. Diabetes insipidus is the exact opposite. And they call it diabetes because they look like diabetics, right? They got polyuria, polydipsia. So let's think about this. Does this make sense? So what happens with diabetes insipidus is here you lack ADH activity, okay? You're lacking your anti-diuretic hormone. So if you lack an anti-diuretic, that's the same as having a diuretic. So it's like having diuretic hormone. So what's happening now is you're peeing like crazy, and your urine. Hang on, I just make sure I got this right. This happens when you get up there sometimes. Yes, you're peeing like crazy. So your urine ends up getting very, very dilute, and your serum starts getting very concentrated. I think I may explain the other one wrong. I hope I didn't with the urine. But anyway, so what ends up happening here is you get very, very dilute urine and a very concentrated serum because and I'm going to go through it one more time because I think I've confused myself. You lack an anti-diuretic hormone, so it's like having diuretic hormone. If you have a diuretic, you pee, so you get dilute urine and a concentrated serum, right? So your sodium is very, very high, and your urine is very, very dilute. That's what happens with diabetes insipidus. How does this happen? There's two ways that you can have it. One is you can have what's called central diabetes insipidus. Something centrally has messed up your posterior pituitary. Okay, and a common cause of that, for example, would be trauma. You've seen this in trauma patients. Somebody comes in, bad motorcycle collision, GCS of 3, you put the Foley in them, and it looks like pure water is coming out. That's because in their trauma, they have just messed up their posterior pituitary. They're not giving you any more antidiuretic, and because of that, you're peeing like crazy and they have a very dilute urine. Very, very bad prognostic sign for these patients, okay? Very, very bad prognostic sign. So it could be central, where you're not making the ADH, or it could be what's called nephrogenic. You're making plenty of ADH, but your kidneys are not responding to the ADH. Okay, that's called nephrogenic diabetes insipidus. Plenty of ADH, but the kidneys are not responding. So because of this, you get polyuria, polydipsia. Like I said, you get a very dilute urine, and you get hypernatremic, where your serum sodium is very high. Now, how do you tell whether it's central versus it's nephrogenic diabetes insipidus? How do you tell whether it's central versus nephrogenic? Well, it kind of makes sense once you think about it. If it's central, if you're not making enough ADH, if you give somebody ADH, it'll get better, right? So if you give them vasopressin, you give them ADH, it's going to get better if it was central, because the problem was they were lacking it. If it's nephrogenic diabetes insipidus, it won't get better if you give them ADH, because they had plenty of ADH. That wasn't the problem. The problem was the kidneys wouldn't respond to the ADH. So central will correct if you give them the ADH. Nephrogenic doesn't get better if you give them ADH, okay? And so treating diabetes insipidus central, the answer is you give them the vasopressin, you give them the ADH. Nephrogenic, and I don't know exactly the mechanism, but the answer here is hydrochlorothiazide. That seems to work for this, nephrogenic diabetes insipidus. Okay, so that's it. And again, if you get confused, like I just did a minute ago, go back through the name antidiuretic hormone, and you can always work your way back through it and figure out what's going to happen with SIADH and what's going to happen for diabetes insipidus. Okay, pheochromocytoma. This is relatively simple. It's a tumor of the adrenal medulla. You remember the adrenal medulla is making your norepi and epi, right? So imagine that you've got a tumor making norepinephrine. It's like you got a little Levophed drip going there, right? And every once in a while, you open the drip and then you close it back off. And you open the drip and you close it back off. And you know what's going to happen in that patient. They're going to get these, these episodes, these surges, where all of a sudden their blood pressure is going to go up, right? So you're going to get these 5 Ps, pressure, right? Increased blood pressure, pain, headache, chest pain, perspiration, palpitations, pallor because of the vasoconstriction. So you're just opening and closing a little Levophed drip. That's what happens with a pheochromocytoma. The reason this is very important is obviously bad things can happen, but also it's another one of these, underlying treatable causes of hypertension. You get rid of the pheo and their blood pressure is all of a sudden fixed, okay? The way you make the diagnosis of this is one of those 24-hour urine tests where you measure the catecholamines and you measure their metabolites, that VMA, what is that vanillyl mandelic acid thing. Okay, whatever. That's mostly an upstairs test, right? Not a downstairs test. But just kind of know that you're going to send the 24-hour urine on that. That's pretty easy. Carcinoid syndrome. Okay, you got to know about carcinoid syndrome, not because you're going to see it every day in the ED, but it's one of those things that they just, if you don't know what it is, they put that in as one of the potential answers, and you'll scratch your head every time if you don't know it. You'll always go, gee, it could be carcinoid. I don't know. I don't remember what that was. So it's just one of those things. Let's just kind of get it over with and know it, so we'll be done. Pretty easy. It's a GI tumor. So you got a tumor somewhere in the GI tract. Appendix, small intestine, colon. You got a GI tumor that's secreting serotonin and some prostaglandins. So if you just remember, GI tumor making some serotonin and prostaglandins. And because it gives these little surges every once in a while of serotonin and prostaglandins, you get these carcinoid attacks. And what they look like is you get flushed, you get watery stools, and the other one I would just kind of circle there is the bronchoconstriction. You get some wheezing. So they're going to tell you, somebody with a blah, blah, blah presents with flushing and watery stools and some mild bronchospasm. That's the carcinoid, okay? That's what it is. So don't let that fool you on the exam. It's pretty simple. Okay, so first of all, congratulations. We made it through all the hormones, okay, of this. So now we're just going to do some electrolytes. We're going to do a little bit of acid-base, and you'll have made it through our favorite endocrine emergencies talk here, all right? So let's do some electrolytes. Sodium. Okay, hyponatremia. First of all, by the way, your brain, if you thought about this, your brain does not like disorders of sodium, right? Like whether it's too low or too high, your brain doesn't like it. Notice that your heart could kind of care less. But with potassium, it's the opposite, right? Your heart cares a lot about potassium, and your brain doesn't seem to care so much, right? So just kind of remember that as a general thing, right? So let's talk about sodium here. Hyponatremia, how does this work? Okay, well, I guess you didn't eat enough salt, but more likely, you got too much water relative to your amount of salt. Remember that your symptoms for hyponatremia depend on how low the sodium is, but really importantly, how quickly you got there. We all have seen this. We've seen a patient with like a serum sodium of 116 who walks into your ED and is fine and gives you like a full-on review of systems, okay? That person did not get there overnight or they would have been dead, no doubt about it. So it's not just how low the number is, it's how quickly they got there. But generally, when you get below 120, things tend to go pretty bad. That's when more of the symptoms get bad. Early symptoms, nausea, headache. Late, you can get really sick, lethargy, and seizures. Okay, now I know this looks very internal medicine-y, and I apologize for that. But there is a purpose for this because it actually will help you for the exam and help you for your practice. So when somebody is hyponatremic, I think the first thing to do when trying to figure out what caused it is look at their volume status. So is the person too wet, too dry, or just right? Okay, it's just kind of like Goldilocks. Too wet, too dry, or are they just right? So let's kind of go through this. What about too dry? They're hypovolemic and they got a hyponatremia. How does that happen? Well, it's because you lose sodium and you're losing fluids. So where does that happen? GI, vomiting, diarrhea, renal, diuretics, third spacing, sweating, burns, places where you lose fluid and you lose sodium. That's the hypovolemic ones. What about the too wet, the hypervolemic ones? Well, these are the things, all your big puffy states where you got lots of fluid. Heart failure, liver failure, renal failure, big fluid states. And what happens here is generally you decrease your effective circulating volume, so you end up basically releasing ADH, and because of that, you drop your serum sodium. If you have a hard time remembering it that way, just think they're big and puffy, they got lots of fluid, so it dilutes out your serum sodium. That's not exactly right, but it'll help it work. So those are the big, big and puffy states. That's another type of thing that can be causing it. And then there's the euvolemic ones, and when they look like they're not too wet or too dry, and those are all the weird causes. SIADH, psychogenic polydipsia, where you're just drinking too much fluid. Hypothyroidism, okay, where it's one of the hypos associated with hypothyroidism. So the weird ones are the euvolemic ones. Too wet, too dry, or just right. We already talked about this. As your sugar goes up, your serum sodium goes down. Another thing we did not talk about is other things that can falsely drop your serum sodium. And this is not true, but a false dropping of your serum sodium is if you have lots of protein or lots of lipid in your blood. So if you send somebody who looks pretty normal to you to the lab, and they call back and say, guess what, their serum sodium's like 112, you're like, what? Like they're alive, this can't be right. You ask the lab, were they lipemic? If there's a bunch of lipid in there, okay, it can actually make your serum sodium look low. And the way this works is, if you think about it this way, just picture that when you send the blood you give it to the machine just counts how many sodium particles are there. It just says, okay, I'm counting how many sodium particles I see. And it assumes what the denominator is. So like if you give them 5 cc's of blood, it says, okay, I got this many sodium particles in my 5 cc's of blood, so here's your concentration. But what happens is if part of your blood is taken up with a bunch of proteins or a bunch of lipids, a bunch of cheeseburger basically in there, they really didn't get 5 cc's of blood. Think of it that way. They got maybe 4 cc's of blood, right? So basically, you're going to have less sodium particles, and it's going to think that you got a low serum sodium. So that's why it happens. So it's a lab error. It's not real hyponatremia. It's just because you got all these lipids or all this protein in your blood, which makes it look like your sodium is low. So that is a real pseudo-hyponatremia. Okay, treating the hyponatremia. Again, it depends on how low it is, and it depends on what caused it. And that's why this kind of volume thing is, too wet, too dry thing becomes helpful. So let's talk about it. What about the hypovolemic hyponatremia? If you're too dry and you need sodium, well, that's easy. You need fluids, you need sodium, you give them normal saline, right? That's the fix for that. What about, I'm going to skip to the next slide and come back. What about if you're too wet? Well, the problem here is you got too much volume here. So you want to free water restrict them, you want to fluid restrict them, and you want to give them some diuretic to get rid of the volume. So that kind of makes sense. And what about the euvolemic? Well, that's the weird disorders, and it's the weird treatment. It's the one where you basically just fluid restrict them. So you pretty much just fluid restrict them. You could add on some diuretic if it's real bad and you want to move it faster, but you basically fluid restrict them, okay? So too dry, give them fluids. Too wet, fluid restrict and diuretics. Just right, fluid restrict. Now what's the deal with the whole, hypertonic saline? Like, I didn't mention that yet, right? Like, when are we going to use that? Well, hypertonic saline, as you know, is going to bring up your sodium a lot faster. Now, in general, when you're trying to correct sodium, you don't want to bring it up too fast. You want to bring it up by 0.5, maybe 1 milliequivalent per liter per hour. So if, that means if you were at, 120, you don't want to get to 140 for 20, 40 hours. And that's a long time, right? So hypertonic saline is going to bring it up real fast, and that can be dangerous. So why would you use it? You would only use hypertonic saline if the sodium's real low, like less than 120, and they're having some bad symptoms. They're seizing in front of you. They're profoundly altered, these sorts of things in front of you. Now you're like, they're in the danger zone. Let's give them some hypertonic saline. Let's get them up a little quicker. Once they're out of the danger zone, disconnect the hypertonic saline, throw it in the trash, and go back to your usual treatments because you don't want to fix it too quickly, all right? So these are for really low sodiums in somebody who's also really sick. Okay, and that's pretty much what that says. Oh, if you correct them too quickly, you can get central pontine myelinolysis, and this is what this next slide is. So, you don't even have to know what this is. But can myelinolysis of your central pons be good, right? Anything you mess up with your brainstem cannot be good. So they get all sorts of bad brainstem things, right? Quadriparesis, locked-in syndrome, we remember that was bad. Dysarthria, dysphagia, you're messing up your brainstem. So you do not want central pontine myelinolysis. Now, I always had a hard time remembering, which one is it if you do it too quickly that they get cerebral edema, and which one's the one that they get the central pontine myelinolysis? And for me, the way I remembered it, again, pretty easily is hyponatremia has the word pon in it, and if you fix it too quickly, you get central pontine myelinolysis, all right? So that's the one that does it. Hyponatremia, central pontine myelinolysis. Hypernatremia gets your cerebral edema if you fix it too quickly, all right? All right, so that's our low sodium. Let's talk about high sodium real quickly here. So how do you get high sodium? Well, yeah, you could go eat a whole pile of salt, but that's usually not what happens. Usually it's because you're just not drinking enough water. And that's not a normal thing, because we all have a very strong thirst drive. When your sodium starts creeping up a little bit, you're thirsty. You're going to start drinking. So usually these are people who don't have great access to water. They're in a nursing home. They can't go over to the water fountain and go get some. They've got a stroke, whatever it is. They're debilitated patients. Those are the patients that get hypernatremic. Bless you. Again, let me see. Somebody going back a slide here. That's fine. So how are you going to treat the hypernatremia? Okay, again, because they're dehydrated, you're going to give them fluid. And you're actually going to give them normal saline. Even though, they have a high serum sodium, you're like, well, why am I giving them normal saline? Because normal saline is still dilute compared to their blood. So you give them normal saline. Here's the formula here that you can use to calculate a fluid deficit. That is to say, depending on how high their sodium is, how much fluid do they need? Okay, you basically take the total body water, which is weight times 0.6 times current sodium over 140 minus 1, okay? So you were to plug that in, for example, if someone had a serum sodium of 150 and you put 150 into that equation, you would come out with 3 liters. Okay? They'd have a 3-liter deficit. And again, you want to replete this over 48 hours. You don't want to do this too quickly here. Again, trying not to bring them up too fast. Bring them up slowly here. Too quickly, cerebral edema. Okay, so that's our sodium. We've blasted through that. Let's do potassium. Low potassium. Okay. Very common electrolyte abnormality. On your EKG with low potassium, gee, you don't kind of see too much. You see like a little U wave, right, which is like an extra wave after the T wave. You're not seeing much until you start to get ventricular dysrhythmias. Then it's got your attention, okay? So that's the thing. You don't have like lots of EKG changes until the bad stuff comes. So you get, you can get some flattened T waves, you can get some U waves, but the biggest thing is when you start popping off these ventricular dysrhythmias. What causes a low potassium? Okay, well you don't eat enough, that's fine, but more likely you're losing potassium, and you're losing it either renal or you're losing it GI, right? You're peeing it out because of diuretics or your DKA or whatever it is, or your GI loss because of vomiting or diarrhea. You can also lose it because of an alkalosis. Remember, if you have an alkalosis in your body wants to fix that, so it wants some hydrogen ion. To get the hydrogen ion out of the tissues, it has to make a trade. So you want some H+, you give some K+, and you put that into the cells. So you're going to drop your potassium by pushing it into cells when you want that hydrogen ion. So alkalosis can do it. Insulin, we already talked about, will drop your potassium. Catechols, your albuterol, things like that will drop your potassium as well. How do you treat hypokalemia? Well, guess what? You give them potassium. What's the best way to give it? Oral or IV? Come on, you guys know this. Best way. Oral. Actually, oral is the best way to give it if you have a choice. So if they have a functioning GI tract and they're not vomiting and things like that, it's best to actually give it oral. You can give much more of it safely oral than you can IV. So you can give them a bunch oral. IV, you can't put more than 40 milliequivalents in a liter, and you can't give them more than 40 milliequivalents per hour. And even when you write that order, you know what your nurse is going to say to you, right? That's too much, that's too fast. Here, they get the binder. Here's the protocol, right? You have that one. Have you seen this? But you give it orally, no one stops you, right? So you can give a bunch PO, and you can give some IV too if you need it, but as long as they got a functioning GI tract, give it to them orally. An important point here when treating hypokalemia, you need magnesium for your kidney to be able to hold on to potassium. So sometimes what you find is you're giving potassium, you keep giving potassium, and you're not fixing it. And it's because they're hypomag. So frankly, what I do is if somebody's got a line in, and I'm giving them all, because you drew the blood, if they're hypokalemic, unless it's like, 3.4 or something like that, and you're already starting to give them potassium, I just empirically go ahead and give them a little magnesium as well, a couple grams, a couple grams over 20, 30 minutes, something like that. And certainly when they're really low potassium, just go ahead and give them the magnesium so that they hold on to the potassium that you're giving them. So remember that you need mag to hold on to your potassium. Okay. What about hyperkalemia, high potassium? Bread and butter emergency medicine, this is going to show up on the boards in some way, shape, or form, and it has to. All right, what causes it? Well, of course, lab error, hemolysis can do it. Ate too many bananas, sure. Decreased output, like renal failure, that would be certainly a classic one. A low aldosterone could do it too. Redistribution, acidosis. So anything that gives you an acidosis is going to start to drive up your potassium. Because remember, now you've got this acidosis, you want to hide it, you want to get rid of that acid, you stick it into your tissues, and you pull out potassium in return. That's why all these patients, they have cardiac arrest, they've been down for a long time in CPR, they had bad acidosis, right? If you measure their potassium, they're all high. And it's not because it was a hyperkalemic arrest, it's just because they had profound acidosis and their body's trying to deal with it, and they start shifting their potassium high. DIG toxicity certainly can do it, right? DIG toxicity can do it. Remember that it poisons your sodium-potassium pump, and because of that, your potassium gets high, and the higher your potassium, the worse your DIG toxicity was. And don't forget about tissue damage, where you just kind of get crush injuries, leak out potassium, and succinylcholine. Succinylcholine, because it's a depolarizing neuromuscular blocker, can cause hyperkalemia. Frankly, even in a normal person, it will cause some mild hyperkalemia, right? And just kind of as a quick review, remember how this works. Again, you got your neuromuscular junction, right? You got your nerve, it releases your acetylcholine, goes across the synapse, goes to those acetylcholine receptors on your muscle, binds to them, causes the muscle to contract. In a normal person, you are about to intubate them. I measure your serum potassium. Let's just say, it's 3 or something like that. Okay. Let's make it normal. Let's say it's 4. Okay. You got a normal person. Their serum potassium is 4. You intubate them by giving a little succinylcholine. If you measure their serum potassium, it's going to go up a little bit, 4.5, maybe 5 at the most. Okay. But it doesn't cause any problems for you because you're normal. You're doing fine. But if you get somebody who's got one of these contraindications of succinylcholine, right? They got cerebral palsy, they've had this, this old stroke, these sorts of things, these burns. These people who've had a denervated muscle, for example, that little acetylcholine receptor is all over the tissue. You go ahead and give them some succinylcholine, and it doesn't leak out just a little bit of potassium, a whole bunch comes floating out. And now your serum potassium, instead of going from 4 to 4.5 or 4 to 5, goes from 4 to 7 or 4 to 8 or something like that. And they widen out right in front of you and arrest. Not a good shift, okay? So that's why you got to be really careful with the contraindications of succinylcholine. Okay, what's your chief complaint with hyperkalemia? What do they usually come in complaining of? They usually aren't complaining of hyperkalemia. I mean, there's not something, it's pretty asymptomatic, right? They're coming in because they missed dialysis. Or they're coming in because, came from clinic, labs, potassium was high, you fix it, right? That's the way this sort of thing works. But they're usually pretty asymptomatic with hyperkalemia. Cardiac changes, you got to know this stuff. This is definitely what happens with the heart, very testable. So what do you get with hyperkalemia? So first, you get some peak T waves. Remember, peak T waves are big, but they're also pointy. They're sharp. They look like they hurt if you put your finger on the top of the T wave. So first you start to get your peak T waves. Then you start to prolong your intervals. You prolong your PR interval. You prolong your QRS interval. That can develop all the way into a bundle branch block. That can degenerate into sine waves. And you can have basically bradycardia and asystole. All right, everyone's final rhythm, asystole. So peak T waves, prolonged PR, prolonged QRS, into a bundle branch block, sine waves, bradycardia, asystole. Those are your progression of hyperkalemia. And you should certainly recognize that on an EKG. So treating hyperkalemia, again, you do this all the time. If you're having cardiac manifestations, wide QRS, first thing you want is calcium. Calcium basically just protects the heart. Doesn't do anything to your potassium level, it just protects the heart from having dysrhythmias. Doesn't last real long, but it has a quick onset, so you just kind of stabilize this thing temporizing. Then what you want to do is you want to hide some of that potassium. You want to try to get rid of it somewhere. So this is when you're using like your insulin to kind of bring it into cells, and of course you give some D50 with it. You're using your bicarb maybe to try to shift it into cells. Maybe you give some beta agonists, some inhaled albuterol to try to shift it into cells. These exchange, now none of the stuff I told you about actually got rid of the potassium in your body, right? It just hit it or protected the heart. So now you want to get it out of your body. That's where this Kayexalate, exchange resins have been classically used. Now, for those of you who follow the literature closely, you know that more recently there's been questions about this, whether it even works at all, whether it's dangerous because it can cause colonic necrosis and things like that. The board exam tends to be a couple of years behind. They're not going to ask you this like trivia cutting edge point. So if they put Kayexalate as an option there, then that's probably a fine answer for treating hyperkalemia. They're not trying to trick you, okay, on the board exam here. But this is basically think of it as colonic dialysis that's meant to bind the potassium and hold on to it. And then, of course, real dialysis works as well, right, to get rid of the high potassium. Another trivia point that you have to know for the exam, if the hyperkalemia is because of DIG toxicity, you want to avoid calcium. Okay, you want to avoid calcium if it's DIG toxicity. Okay, it can cause worsening cardiac complications. Again, for the exam, if they ask you that, that's the right answer. In real practice, just so you know, it's like animal studies. Some toxicologists don't believe it. There's a nice debate on it, but we're not going to debate for the board exam, all right? For the board exam, if it's DIG toxicity with hyperkalemia, don't give calcium. Okay, so we did sodium, we did potassium. Now let's do a little calcium. Let's whip through it. With calcium metabolism, there are 3 big players: parathyroid hormone, vitamin D, and your kidneys. And when something's going wrong with the calcium, it's usually something that involves the parathyroid, the vitamin D, or something with the kidneys, all right? So these are your big three players here. Parathyroid hormone, its job is to raise your serum calcium level. That's what it does, okay? It, bone resorption, all these things. So, you chew up your bones, your kidneys respond to it, your GI tract responds to it. Its job is to raise your serum calcium. And by the way, while it's raising calcium, it's lowering phosphate. They're going in opposite directions. So that's what parathyroid hormone does. Vitamin D. Vitamin D, if you remember, is made by the kidney. It's activated by sunlight, so you need to get some little sun exposure to have some vitamin D or drink it in your milk, right? And you need it for GI absorption of calcium. If you don't have your vitamin D, you can't absorb from the gut your calcium. So you need that. That's a big player. And then the third player is the kidneys, and they have a dual role. One is that they make the vitamin D, which I already just talked about, and two is they're a filter. They help hold on to calcium themselves when you need it as well. Okay, so parathyroid hormone, vitamin D, and the kidneys. So what causes hypercalcemia? There's a lot of things that do it. You probably don't have to memorize everything on this list. There's different mnemonics. There's Pam P. Schmidt. I learned the less politically correct one, which was Madam Fat Hips, okay? But I didn't make it up. It was taught to me. That's all I'm just telling you. But if you like those mnemonics, go for it. Let's just kind of go through some of these that are important. So this is certainly you got to know. Parathyroidism, right? Hyperparathyroidism. I just told you. You got too much parathyroid, its job is to hold on to calcium. So that's pretty simple. Addison's disease, okay, fine. Multiple myeloma, sure, we get a lot of bony destruction. We should know that one. Paget's disease, you remember how it messes up your bones, they get all opaque. Yeah, that makes sense. Sarcoid, okay, whatever. Cancer, that could happen. Bony destruction, or some of the cancers can actually secrete a PTH-like substance. So I think you ought to know that one, know the cancer. Hyperthyroidism, remember, increased bone turnover. It's one of the hyper things where everything goes up. Milk alkali, what the heck is that? That's a real internal medicine-y. Probably wouldn't ask you that one, but just in case, this is where somebody, is like taking too much calcium by mouth and maybe some antacids with it or things like that. So they get hyperabsorption. They get hypercalcemia and they get an alkalosis as well, milk alkali syndrome. Immobilization, yeah, probably should know that. Your bones start to turn over, right? Vitamin D, got to know that. It's one of the big threes. Vitamin D, too much vitamin D, you absorb too much, you get hypercalcemia. And I think you should memorize thiazide diuretics. I don't know how it does it. I just know that it's like every board review book you ever see, they always ask you about the hypercalcemia and thiazides, so you got to know that. The thiazides will cause hypercalcemia as well. But there's the mnemonic if you like it, and there's some of the ones you should know. So what does hypercalcemia look like when someone's got it? Stones, bones, moans and groans. And someone say, and psychic overtones, okay? So I'm going to tell you the ones you need to circle here. Neurologic, you're altered and weak, okay? So these people are altered and they're very weak. On your EKG, you get a short QT. So high calcium, short QT. Be a great EKG question. They show you the EKG and you got to figure out what's going on, right? High calcium, short QT. Renal, you get polyuria polydipsia because you have a nephrogenic diabetes insipidus. These patients, the calcium is like a diuretic. It like makes you pee like crazy, okay? And you get kidney stones. So you got to know the renal stuff. For GI, belly pain. They get lots of belly pain. Oh, so they're altered, they're weak, their belly's hurting them, they got some kidney stones, they got their short QT. And then I would also know bone pain is the other one I would circle. You just get lots of pain all over. These people are not really happy campers when you got severe hypercalcemia. Treating it, it's the slide lists a number of things here, but the thing, if you just want to remember, the main thing is saline diuresis, okay? So you need a bunch of fluids, a bunch of normal saline to start getting rid of that calcium, and once you've given them plenty of fluids, you can start adding some furosemide, not thiazide, right? You can add some furosemide to help get rid of the calcium as well. That's what you're going to do down in the ED. You're going to give them a bunch of fluids, you're going to give them some furosemide. There are some other things you should know about because they could show up on the exam, but they're really mostly upstairs sort of drugs, not things we do. So biphosphonates, this is like etidronate, pamidronate, these sort of things. These inhibit the osteoclasts, those little Pac-Men that chew up your bone, okay? So that's one of the things that they can do as well, so you don't chew up your bones as much. Calcitonin can do the same thing as well. Steroids they use sometimes. Of course, dialysis they can use as well for this. But the mainstay thing that's likely to show up on the exam, fluids, lots of fluids, and then some Lasix. And then just know that these other things can be used too. What about low calcium? Okay, why is your calcium low? You messed with one of the big three. You mess with one of the big three. You have hypoparathyroidism. You went to have your thyroid taken out, and hey, for no extra charge, they took out your parathyroids too, all right? So you have a low parathyroid, so you get hypocalcemic. Renal failure. Kidneys aren't working. They can't absorb the calcium. They can't make the vitamin D. Vitamin D deficiency. You can't absorb it from your GI tract. So those would be really classic mess with the big three causes. Other things, pancreatitis can do. Remember the Ranson's criteria? Remember that for like, when is pancreatitis bad? If you have this and if you have that, if you have this. One of them was the low calcium. That's because in severe pancreatitis, you basically start to bind up your calcium. So that's what happens there. So bad pancreatitis can cause hypocalcemia as well. Forget all the list of drugs. You're not going to know those. DeGeorge syndrome I will mention as well. DeGeorge syndrome, now listen, don't like throw tomatoes at me. Remember those like branchial clefts from embryology, okay? Bottom line is the one that was supposed to make the parathyroid didn't, okay? So these are basically kids born without a parathyroid. So they don't have their parathyroid hormone, so they get hypoparathyroid and they get recurrent and bad hypocalcemia, okay? So that's a kid with recurrent hypocalcemia. All right, what does it look like when you've got hypocalcemia? Your nerves don't like the low calcium. They get real irritable, real twitchy, real jerky. You get paresthesias and hyperreflexia, those sorts of things. Remember Trosteck's sign and Trousseau's sign? Which one's Trosteck's? There you go. So this is where you're tapping here in front of the ear on the facial nerve, and the facial nerve is so irritable that just by tapping on it, you make it fire, and it starts doing this to the corner of your mouth, okay? So just tapping on it makes that fire. Trousseau's sign, you put a blood pressure cuff on somebody, you pump it up, you leave it on for a little bit, and they start getting that carpal spasm. Everything's just real irritable. They get this carpal spasm like that. And the way I remember it is Trosteck's cheek. Trousseau's the other one, okay? All right, EKG. Remember, low calcium gives you a long QT. High calcium gave you a short QT. So just, you got to remember that for the exam for sure. Treatment is pretty simple. If they're hypocalcemic, you give them calcium. And usually you just give them a bunch of calcium gluconate. That's the main thing that they would ask you about. I don't think they'd ask you about the mag. Okay, magnesium. We got one slide for both high and low mag. Okay, we're going to be real efficient on this one. Hypermag is pretty rare. You don't see it a lot. When are you going to see it? Renal failure, right? Renal failure, you can't get rid of your mag. The other time you're going to see it, iatrogenic. Someone's got preeclampsia, we put them on a magnesium drip, and now they're hypermag. Remember what the first sign is of hypermag? What do those OBs check? Reflexes, right, so hyporeflexia. That's the earliest sign is you start to lose your reflexes when you're hypomag. So you can basically get hyporeflexic, and you can get weak, and that can get all the way to respiratory depression if you don't fix it. So it's going to be a renal failure patient or somebody who's on mag, and they're going to get hyporeflexic and weak. The antidote for magnesium is calcium, just like treating hyperkalemia, same sort of thing. So somebody's hypermag and they're having problems, you give them some calcium. So that's hypermag. Hypomag you see every day in the emergency department. Whether you're measuring it or not or realize it or not, you definitely are seeing hypomag patients. They're very, very common. Malnutrition, alcoholics, diuretics. They've looked at studies of patients in ICUs. Lots and lots of them are hypomag. So, you know, hypomag is a very, very common thing. The symptoms kind of similar to hypocalcemia with this kind of, you know, twitchy, jerky sort of stuff. Remember that your serum levels don't necessarily correlate that well with your tissue levels. So, and that's why getting mag levels per se isn't always incredibly helpful. For some patients, like I said, I just empirically will treat with mag if I'm worried about it. But the treatment for low mag is mag, pretty simple. Give it, you know, depending on how low it is, you give them more and more. 2 grams, 4 grams, sometimes they need more. So that's it, high mag versus low mag. Okay, phosphate. Let's try to make phosphate pretty easy. How does metabolism work? You eat it, you absorb it, you pee it out. That's the way it works. Remember that parathyroid hormone's job is to raise your calcium, but while it does that, it lowers your phosphate. And so if there's an issue going on with your parathyroid itself, they're going to go in the opposite direction. If calcium's up, phosphate goes down. If calcium's down, phosphate goes up. That's because that's what parathyroid hormone does, is it makes them go in opposite directions. Oops. So how do you get high phosphates? Well, you're going to get a high phosphate if you have a low parathyroid, right? Low parathyroid, you'll have a low calcium and a high phosphate. So if something is messed up with your parathyroid, you're going to get a high phosphate. Renal failure, you'll have a high phosphate because you can't pee it out. And then frankly, and people get confused about this sometimes, anything that causes your calcium to be high for some other reason, like too much vitamin D or you ate a whole bunch of calcium. If your calcium is really, really high to begin with, you get a secondary hypoparathyroidism. That is, your body says, whoa, my calcium's too high. I got to lower my parathyroid level. And when you do that, just like I said in the beginning, you're going to get a high phosphate, okay? So it can be primary where the parathyroid's not working. It can be secondary because you are hypercalcemic for whatever reason and your parathyroid is responding to it and trying to fix it, okay? What else? Hyperphos, symptoms are usually, it's really due to the hypocalcemia that comes with it. Treatment for high phosphate, you got these oral binding gels, you know, these phosphogel, whatever we call it, Renagel, these sorts of things that basically bind up the phosphate and treat the calcium part too. Okay, what about low phosphate? What's going to cause a low phosphate? Well, remember, hyperparathyroidism or cancers that, you know, will do this because of secondary causes. Decreased oral intake, you know, you're alcoholic, whatever. Increase output, you're diabetic, you have diuretics, you're DKA, peeing the stuff out, that sort of thing. So either decrease input, increase output, or hyperparathyroidism. Signs of hypophos, remember, you need phosphate for ATP, ATP for energy, so you get weak, respiratory depression, those sorts of things. Treatment, you just give them phosphate. So you just give them a little oral if it's mild. If it's severe, you got to give them some IV as well. So we've done all the hormones. We've done all the electrolyte stuff. We're just going to hit a little bit of acid-base stuff, and you'll make it through. So let's go to our friend, the anion gap, and this is important. All right, look, if you were looking at somebody's blood, they got some positively charged stuff going along there, right? They got sodium, you got potassium, you got proteins, you got lots of positively charged things. You got negatively charged things going on in your blood as well, right? You got your chloride, your bicarbonate, you got lots of other negative things. And in life, you know, there's a nice yin and yang. It's all nice and balanced, right? Your positive things, your negative things, it's all balanced out. There is no gap, right? Because life is all balanced in your blood. However, when you send your chemistries, we send a Chem 7, not a Chem a million. Right? So we don't measure everything. So because of that, there's a gap. There's supposed to be a gap because we haven't measured everything. And this is the formula down here, right, that you have to know. The way you calculate an anion gap is you take the sodium, the positive thing, and you subtract their chloride and bicarb from it. And that's going to give you a gap normally because we haven't measured everything. And normally the gap is less than 12 or 14 depending on your lab, all right? So that's why we have an anion gap to begin with. We haven't measured everything. Now, before I talk about mud piles, and you know what's coming, right? All the things that cause an elevated anion gap, let's talk about what would cause a narrow anion gap. How would you have a low anion gap? Going back to our formula, right? The only way you can have it is if your sodium's low or one of those things is higher, right? So that could certainly happen. But let's talk about how that might happen. I want to give you a few specific things that are worth understanding. And that's what's on this slide here. If you have a bunch of positively charged things, or if you lose a bunch of negatively charged things, your body's going to try to compensate by having some extra bicarb. So for example, let's say you've got multiple myeloma, hypercalcemia, hypermag, lithium, all these extra positively charged things around. Your body says, whoa, too much positive, I need some bicarb. So you get some more bicarb, and because of that, you narrow your anion gap. Similarly, if you lose albumin, turns out albumin's negatively charged. If you got nephrotic syndrome, you're peeing it all out. you're losing all your negative stuff. Your body says, hey, I need some negative stuff. So you get to hold on to a little more bicarb, and again, that narrows your anion gap. So lots of positively charged things or a loss of negatively charged things can narrow your anion gap. Okay, so I want you to know about that. The other special thing I want you to know about for the board exam is bromism, bromide. Bromide is Br negative. Chloride is Cl negative. When you send off somebody's blood to the lab for their chem panel, it can't tell the difference between the two. So if someone's got bromide, it reports it out as chloride. So because of that, looking at our formula, if somebody had a bunch of bromide, you get their chemistry, and what really happens is their chloride gets reported out very, very high. And because of that, they have a smaller anion gap. In fact, you can have a negative anion gap with bromide intoxication. So if you ever see, you do the math and it's a negative anion gap, it's not really the chloride, it's something else there, it's bromide that's causing it, all right? Those are the things that cause your low anion gap. Okay, hopefully that makes sense. Now we come to mud piles. So if you get somebody on the exam and they show you their chemistries and they got, you know, an acidosis, the first thing you got to do is calculate the anion gap and say, is it an elevated gap acidosis or is it non-gap acidosis? Because that's going to help you figure out what's going on. And if it's a gap acidosis, you go directly to mud piles, because the answer is almost always here on this slide for what's causing it. M for methanol, U, uremia, D for DKA, but also alcoholic ketoacidosis or starvation ketosis. P for fenformin or paraldehyde. Fenformin is like metformin. It can cause a lactic acidosis. It's actually now taken off the market, but they still could potentially ask you on the board exam, I guess. But fenformin or paraldehyde is your P. I for iron or INH. L for lactic acidosis, E for ethylene glycol, and S for salicylates. So if you remember that list, and I don't remember a lot of mnemonics, but this one I do, because this one actually does help both in the clinical practice and on the exam. Elevated gap, go to mud piles. Lactic acidosis, that's the L in mud piles. There's different types of lactic acidosis. You don't have to know type this, type that, but let's just kind of go over it conceptually. One type of lactic acidosis is hypoperfusion. I go try to walk up to my room, I'm going to develop a lactic acidosis. Another type of lactic acidosis is because of some sort of medical condition, like seizures or liver failure. Those patients get lactic acidosis. And then another type of lactidosis is associated with drugs or toxins. And you should know some of these, and I would circle a few of these. Toxic alcohols, you got to know. Metformin, we've talked about that a bunch now, can cause a lactic acidosis. And the antiretrovirals for HIV, some of those can cause lactic acidosis. So you should know those three, all right? So hypoperfusion, medical conditions, and lots of different drugs, but the ones to remember are the toxic alcohols, the metformin, and the antiretrovirals. Okay, so what about a non-gap acidosis? I mean, how the hell do you get a non-gap acidosis? Well, you get an acidosis because you're losing bicarb, right? You're losing your bicarb, but you're losing sodium too. And because of that, you don't mess up the equation. You lost a positive and you lost a negative, right? If your sodium goes down by 2 and your bicarb goes down by 2, you have the exact same anion gap in your formula. So that's how you get a non-gap acidosis. It's where you're losing sodium and you're losing bicarb at the same time. There's a mnemonic here called hard up. If you like that, I won't comment, okay? But there's your mnemonic if you want to remember that. The way I remember this is actually renal and GI. Almost any cause of a non-gap acidosis, it's going to be renal or GI is going to be the answer there, okay, on the exam. So let's just kind of go through it. Okay, hypoaldosteronism. Okay, that's adrenal. It's right next to the renal. Give me a bone there, all right? Acetazolamide, that's renal. That's a diuretic. Renal tubular acidosis. Diarrhea, that's GI. Let's skip down for a second. Pancreatic fistula, right? Pancreas, part of the GI tract. And ureterosigmoidostomy. It's both renal and GI stuck together, right? Make sense? So it's renal and GI is what's going to cause your non-gap acidosis. Pretty straightforward. Okay. What about metabolic alkalosis? So now we're talking about alkalosis. How do you get alkalotic? You either have too much bicarb or you've lost hydrogen ion somewhere. Okay? So where are you going to lose hydrogen ion? Well, Pretty easy, right? Gastric acid, that's a good one. So vomiting, NG suction, you lose it. Diuresis, you can lose your hydrogen ion. How do you get too much bicarb? Well, someone gave you too much bicarb, or maybe you got blood transfusions with citrate and lactate that get converted into bicarb, for example, or antacids with our milk alkali syndrome where you're absorbing all this bicarb, all right? So those are the things that you're going to most likely see with metabolic alkalosis. People talk about chloride sensitive versus chloride insensitive. I personally don't think this is a big deal. I don't think they likely would test you on it, but they could. So let's just kind of do it real quickly. Chloride sensitive just means you're volume depleted. So when somebody who's dry and alkalotic, which we see all the time, right, that's chloride sensitive, and it responds to saline, to fluids. So you give them normal saline, they do better. That's what that means. Chloride insensitive are those kind of weird causes. You're not dehydrated. You're euvolemic. You got mineralocorticoid excess or something like that, renal artery stenosis. And so giving them IV fluids doesn't make it better, okay? But just remember, chloride sensitive means you're dehydrated, metabolic alkalosis, and it gets better with fluids. Simple. Okay. I think our last thing to cover here is osmolality. So basically, you remember you got lots of stuff floating around in your bloodstream, and they all have little different molecular weights and things like that. But if you measure them all and add them up of all the stuff floating around there, you get a osmolality. And you can send your blood to the lab and actually have them measure what your osms are, okay? And the big things that are kind of determining your osms in your blood are sodium, glucose, okay, and your BUN down there in your formula, all right? So you need to know how to calculate a serum osms, to estimate it. Now you're like, why do I calculate it? I can just send it to the lab. We'll talk about why it's important in a minute. So how do you calculate someone's osms? Here's the formula, and you got to remember it. Twice the sodium plus the glucose over 18 plus the BUN over 2.8. Okay? And that's a kind of estimation, a measurement of what their osms are. And by the way, I always had a problem remembering which number went under which number until I kind of realized, okay, the big number goes under the big number and the little number goes under the little number. Okay? So if you have problems with that, that hopefully helps them make sense. So you take the person's blood, or they give you on the exam a chemistries, and you say, maybe I'll calculate out their osms. And you put the formula in, and you come up with a number, okay? And normal, by the way, is like 280 to 295. So let's say you measure that, you calculate it out, and it's 280, just like it's supposed to be. But guess what? The measured osms, when you actually sent it to the lab, was 300. Something's going on there. It means that there's something in the lab that's not on your formula, right? That's the osmolar gap. And normally, your gap should be less than 10. You can get up to 10 of stuff that the lab measures that you don't see in your formula. But when it's over 10, there's something else in there. And probably the answer on the board exam would be one of the toxic alcohols. So if they ever give you chemistries and an osms, that means they want you to calculate the osms and compare it to the measured osms and look for that osmolar gap, okay? That's a real important thing. By the way, ethanol, just good old-fashioned alcohol is certainly one of the other things, and some people will put that in their formula as well. For that, if you wanted to know, just for your own knowledge, it's ethanol divided by 4.6, okay? Ethanol divided by 4.6. And by the way I remember that, because I always had problems with that, you see here, your 18 and your 2.8. If you put a little point there and made that 1.8, 1.8 plus 2.8 is 4.6, okay? And that's how I've kind of remembered that 4.6 is under there. I know it's crazy, but it works for me at least, okay? That's how I remember the 4.6. So yeah, if somebody's drunk too, yeah, you might want to go ahead and put the 4.6 in there too and correct for that. But the key thing, they give you the osms that are measured. You need to calculate it. You need to compare it. If there's a big osmolar gap, go directly to toxic alcohols. All right? So with that, thanks for your attention.